Okay, for the next talk, we're going to be discussing the preparation of a research protocol. So coming back to our conceptual framework here, we now have our clinical question or clinical idea that struck us in the operating room. We've now turned it into a robust and testable research question. And now we're going to be taking that research question and actually adding on some of the more important details that are actually going to go into a proposal. And that could be a proposal to the IRB, proposal for funding, really just taking things towards the next step of actually conducting your study. So the learning objectives here are to just define a few terms that are really critical for a proposal, eligibility criteria. We'll talk a bit more depth about outcomes, and then we'll go into weeds a little bit on sample size calculation because it's often a big stumbling block. And then we're going to discuss something a bit about the ethics of research and the importance of conducting of responsible conduct of research. So we're going to continue along with the same example that we have been using, which is this randomized trial comparing intramedullary nailing and external fixation for open tibia fractures. So the kind of first bit of detail that we're going to want to add on for a research proposal is to further specify our study population, and that's done using eligibility criteria. And this is what will be used during a study to screen patients who may be eligible and determine who can be included and who should be excluded. So it's sort of a checklist, but it really specifies who the target population in the study will be. And I think a lot of times there's a temptation to really try to add lots and lots of these inclusion and exclusion criteria to create this really homogeneous population, which from an experimental perspective is a good thing to have a lot of homogeneity. But it has some downsides as well. If you go too homogeneous, then first of all, you may compromise a lot of your sample size and make it hard to conduct the study. We'll talk about that more in a second. The other downside of if you is that you lose the ability to generalize your results to more broad population. So if you make it all about left-sided, proximal 1/3 open tibia shaft fractures with wounds that are between 5 and 8 centimeters, I mean, you'll have a very specific population, but you won't be able to generalize your results and you'll have a hard time finding those patients. So that's kind of the key thing. That's the argument to avoid being too restrictive with your sample size. On the other end of the spectrum, if you do go too broad with your eligibility, you may end up with a situation where you have patients in your study who respond differently to your intervention and in your control. So maybe open and closed fractures might have very different responses to your intervention and your control. And if you lump them all together, you may find that it washes out the effect that you're interested in. So you kind of have to find the balance here of this target population that's appropriately specific to address your research question, but still have adequate sample size and the right degree of homogeneity to see the effect from your intervention that you're interested in. Just coming to our example, in this case, we've specified our inclusion criteria, our OTA type 42 tibia fractures. We're going to focus on the shaft fractures because, getting into tibial plateau fractures and pilon fractures might behave very differently. The treatments are very different. We can't really use nails in all cases and things like that. We're going to specify that it's Gastilla type 1 to 3A because, the injuries requiring flaps, that there are a lot of other issues there that, they may behave very differently, have much higher rates of infection independent of anything that has to do with our fixation, similar with vascular injuries or other things. And then kids have very different response to treatment than adults. They heal fractures differently. So we're going to specify adult patients for inclusion criteria. So this is kind of the initial first pass of patients that we think could be eligible to be in our study. And then we're going to apply our exclusion criteria. So these are the things that once we've identified those patients, we're going to gather some additional information and use these criteria to exclude some of them who might not be good for our study. So one example might be patients who present very delayed. In this case, we chose 24 hours, but it could be a bigger delay. The concern being that if somebody's so delayed and has a very contaminated fracture, we may not want to put a nail in those patients. We already talked about the issues about flap coverage and vascular injury, and other issues that might come up would be things like patients with severe head injury may not be able to participate in some of your outcome assessments and things like that. You might exclude patients who have certain risk factors that may prevent them from following up. Things like that also might influence the mechanics of the study. Could be things that you want to keep as exclusion criteria. Now that you have eligibility criteria, we can talk a bit more about outcomes. So as we've mentioned, you can only really have one primary outcome because you have to power your study around something. You can only pick one study or one thing to power the study around. But you might want to have additional outcomes that you measure, because sometimes the primary outcome, it might be the most important outcome, but it may not. You may want to have some additional outcomes that help explain the mechanism behind the primary outcome. For example, if the primary outcome is quality of life, and you find a difference in quality of life between the two treatments, you ask why. Is it because they have a higher infection rate? Is it because they're healing less quickly? What's driving that difference in the primary outcome? And so that's where secondary outcomes become very important. But you can't make as strong a conclusions about the difference between the two interventions with secondary outcomes that you can using the primary outcome, because it's not powered for those differences. The other thing that's important about outcomes that we haven't talked about is timing. So, and timing could be both the duration of time or time point that you're going to assess the outcome, and sometimes you might assess it at multiple time points. So, and you want to specify what that interval is. And this is going to depend on what the outcome is. So, for example, if your outcome is, you know, um, infection or let's say even length of stay, then it's going to be a very short period of follow-up that's required. But if you're interested in post-traumatic arthritis because you're worried these tibias are getting malunions, that may take decades of follow-up to detect. So it might be very interesting to look at that, but that may or may not be feasible. So the timing of the outcome is also very important and may ultimately influence feasibility as well. This is, I think, a nice conceptual framework that I use when thinking about outcomes. Basically, the idea here is that whatever clinical problem, injury, or disease that we're looking at, there's some, underlying biology that's pathologic. That pathology leads to some symptoms that the patient experiences that may or may not influence their function, which may or may not influence their perception of their health, which may ultimately influence their overall quality of life. And so we can measure outcomes anywhere along this spectrum. If we measure close to the left side at the, the root cause sort of problem, it's easier to detect differences. But it's very often the case that those differences we see at that level may not translate to an actual difference in quality of life. So if we come to our example of the open tibia study, an example of sort of a biologic variable would be measuring X-ray healing. It could be X-ray healing or X-ray alignment. For healing, it could be the Rust score, and that's getting at the root of, is the bone healing? But we've all seen cases where the bone either didn't heal or healed slowly, and the patient doesn't necessarily always have symptoms. So we might go one step closer and measure pain or pain scores, and that's getting us a little bit closer towards quality of life. For function, we could ask if they could do a squat and smile. There's a number of other functional tests we could ask, or what their walking tolerance is. For quality of life, we can look at, there's a number of quality of life scores out there. The EQ5D is a simple one that we often use that measures a patient's health-related quality of life. And lastly, we could look at clinical endpoints that matter to patients' quality of life, like having another surgery or a major complication. And the key thing with this is that the thing that we're probably we would all agree is most important is, are we improving the patient's quality of life? But the further we measure on that end of the spectrum, the more sort of noise we might get from different aspects of the patient. What's their pain tolerance? What are their, what's their baseline functional level, as well as their environment? How much help do they have? How much social support do they have? So I think the key thing is to try to measure across this spectrum as much as you can. So choose a primary outcome that's probably closer to the the right side of the scale towards quality of life and what really matters to patients, but make sure to measure the secondary outcomes across the spectrum so that you have an understanding of what the mechanism is that's leading to the differences in the more clinically important outcomes for quality of life. So here's an example. So in this study, we're going to look at a primary outcome of reoperation, but there's a number of secondary outcomes that we can look at as well, both radiographic alignment, radiographic healing with the RUS score, and that again is on that biologic end of the spectrum. We can look at a quality of life questionnaire, which is getting further to the other end of the spectrum, and then have a squat and smile, which is kind of in the middle as a functional outcome. Now that we have our outcomes, we can think about power and sample size. And this is, I think, we're going to try to stay away from, getting in the weeds of statistical analysis and bore everybody with statistics. But if there's one kind of statistical concept that it's important to understand, I would say it's this concept of power, which is the probability of finding a difference when one actually exists. I could probably say that 10 times and I still don't totally know that it takes a while for that to wrap your brain around that concept. Perhaps a better way of stating is what happens if you don't have enough power. And basically what happens if your study is underpowered, meaning the sample size is too small, is that your study will show no difference even when there's a difference between the two treatments that you're interested in. So it's a source of negative studies, and you don't really want to do it's not ideal to conduct a study that's too small and conclude there's no difference when in fact there actually is a difference between the two treatments. And so we can try to predict that by doing sample size calculations. We can try to anticipate how many patients we would need to see a meaningful difference. So how do we do that? There's a number of inputs that go into it. And, it's a little beyond the scope of this to go in too much depth, but you have to know the type of outcome, whether it's a binary outcome like reoperation or a continuous outcome like quality of life. You need to know what difference you're trying to detect. Do you want to detect a little tiny difference, which is going to require lots of patients? Or are you okay detecting a larger difference, which won't require such a large number? You need to know about variability in data. You know about the desired power. So that's sometimes called type 2 error. So that this standard for this is 80%. So you want to have 80% confidence that if you have a negative result, that it's truly negative. And then the alpha, which is the other side of it, which is that if you do find a difference, what's the probability? What's your confidence level that that is true? And, for this outcome in this example, we're going to say that our primary outcome we decided was reoperation. So that's a dichotomous outcome, meaning it's either yes or no. The difference that we're going to try to detect is 20% versus 10%. We'll talk about that a bit more in a second. With binary outcomes, there's no measure of variability. There's no standard deviation that we have to think about, which is nice. The power, as I mentioned, is typically 80%, and the standard for the alpha is 5%. So those inputs, generally speaking, are pretty consistent regardless of the study. These are kind of the standards. Some people would argue you should have 90% power, but the general minimum is 80%. The general standard for alpha is 5%. So this is kind of a cool resource. You can do the sample size calculation using, all statistical software generally has a package or a command for doing this. But this is a nice free website that UCSF has that you can punch into your browser if you want to do this calculation. It's just samplesize.net. And when you go to this website, you'll see the different types of outcome measures. You just click the link and then you can put all these numbers in there for your particular study. It's going to default give you an alpha of 0.05 and a beta, which is the kind of 1 minus the power. So a 20% beta is equal to an 80% power. And then we can put in our baseline risk, which is 10%, our risk in our two risks, which are 10% and 20%, and then that's going to give us our calculation. And so you see here that with these inputs that I specified here, it would require 400 patients. And on top of that, and to make things even more complicated, you have to anticipate loss to follow-up. So if 20% of the patients aren't going to come back for follow-up, then you actually have to have 500 patients in order to count for that 20% loss and still have 400 patients left. So that also gets factored into your sample size calculation. But this is basically how you do it. We'll just talk a little bit more about, effect size, because it's probably, of all the variables in there, this is one of the harder parts of the calculation to know what to put in. And it's sort of a tension between two different things. On the one hand, you want the difference you choose to be the smallest effect size that would be sort of clinically meaningful. But you can see that if I look at an effect size of 1%, so if I'm, in this case, it would be a reoperation rate of 10% versus 11%. If I thought that was clinically meaningful, then I would need almost 30,000 patients, which is just not feasible. If I say that what's clinically meaningful is 10% versus 15%, then it goes to, 1,370 patients. And then at 10%, which I think we would all agree at 10% versus a 20% difference is clinically meaningful, then we need 400 patients. And we're going to say that in our case, that is feasible if you have a busy center. But you have to look at how many patients are you getting, per month, per year, and how long is it going to take you to accrue this number of patients? Can you do it at just your center? Do you need additional patients? So these are all the considerations that kind of go into this sample size discussion. So the kind of key points are that it's based on the primary outcome. In general, more patients is going to be better, and that it's probably the single biggest barrier to studies being feasible. And so you really want to spend a lot of time thinking about this and kind of iterating on your study design to ensure that this is feasible. So now we're going to switch gears a little bit and talk about research ethics. Some may have read about this, others may have not, the Tuskegee syphilis study. This is one of the sort of darkest examples from U.S. history, and arguably research ethics as well. But it's something I think everyone should know about, because I think it's a powerful example of research gone bad. So this was a study, again, it went on over 40 years. The idea, it took place in a predominantly African-American part of the United States. And they enrolled patients who had a diagnosis of syphilis, and then were trying to see what the effects of syphilis were over time untreated. They wanted to look at the natural history. And what happened over the course of that period of time, over these decades where the study was going on, is that new treatments came out, like penicillin and other things, that syphilis became a very treatable disease. But they didn't inform the patients about those treatments. They didn't inform them about the goals of the study. And so, it's really kind of one of the worst examples of irresponsible conduct of research. And I think it's from the study, a lot of the guidelines and regulations around research ethics have kind of come from this. That's the reason why we have to go through an institutional review board for the vast majority of studies that we do. So I encourage you to read about it if you haven't before. It's very sort of appalling and sad, but also, important history to understand, so that we don't, repeat these mistakes. So, just to drive this home, we have to remember that no matter what the study we do, there's almost always some small amount of risk to the participant. Even if it's just a retrospective study with charts, you're still going to be gathering data and patient information, and that does expose them to some risk. When you start talking about interventional studies, like a randomized trial where you're going to change their treatment, then the risk becomes, significant, because the treatment is going to be different based on their participation. And so we really want to make sure that all patients are fully informed and understand the pros and cons of participation, and understand that they do not have to participate, and that if they choose not to participate, that their care will not be any different. And that's just, extremely important. IRBs, institutional review boards, are something that we often like to complain about because they slow down our progress and prevent us from starting our studies as quickly as we would want to. But they are really an important resource and protect our patients from our sometimes overzealous desire to conduct studies and get answers to these questions. And so just it would encourage you to consult your IRB, get to know the people that work there, and understand the rationale for why they exist and what why their recommendations are in place to protect patients. So just some take-home messages. Remember that your target population is defined by your eligibility criteria, the inclusion and exclusion criteria. You can only really choose one primary outcome, but you can choose secondary outcomes across a spectrum from the root cause of disease all the way up to quality of life. And those can be kind of the way of optimally understanding the effects of your two intervention and comparator. When it comes to sample size, more is better. And remember kind of the issues with effect size and how you want it to be, choose an effect size that's clinically meaningful, but still feasible for you to conduct at your center. And then last, but definitely not least, do no harm, protect patients, conduct research responsibly, and consult your IRB before starting your study. Thank you.